Hello and happy Teach Me Tuesday. My name is Lisa Houston and I'm a clinical nurse educator specializing in the NICU. For today's Teach Me Tuesday, we are going to talk about intubation in the NICU. Last week, we ended up talking about respiratory meds, and I just kind of got on this kick of what more can we talk about in relation to respiratory. We've talked about intubation kind of roundabout in many ways. We talked about it when we did our NRP review. We talked about it when we talked about respiratory escalation. And of course, we've talked about it with some of our congenital heart defects. But today we're just going to talk about what intubation is, what supplies you would need, what medications we use prior to doing intubation, and just what would you as a bedside staff member, whether you're a NICU nurse or a NICU RT, need to know to be successful at the bedside assisting the person that's doing that. I do not intubate. I am not certified to intubate. I've never gone through a training or done any special course for that. So this is an overview from kind of a bedside nurse's perspective. What would be expected of you to be doing during intubation? Additionally, I am an NRP instructor, so I have talked people through this, and I've intubated a lot of mannequins. Very good at those little mannequins that don't breathe, have actual secretions, cry during it, or move. So basically, I'm an expert in nothing. But let's talk about it. Intubation in the NICU is a life-saving intervention. We don't take intubation lightly, and in fact, intubation happens less and less every year of my career. When I first started as a little baby NICU nurse almost 21 years ago, we intubated pretty much every baby that was born prematurely. I'd probably say, I don't know, if I was a guessing lady, if you were born less than 28 weeks, we were intubating you. That's just kind of how it went. And now we do so much non-invasive ventilation and non-invasive ways of giving surfactant that we don't intubate as many babies as we used to. But if needed, we do have it. Premature babies are often going to need it for their underdeveloped lungs, especially in the setting where they did not receive steroids prior to delivery. So mom did not receive steroids prior to delivery. Full-term infants might need it during meconium aspiration, a delivery complication such as shoulder dystocia or placental abruption, if they have sepsis or any of those congenital anomalies that we talked about a few weeks ago, including heart defects. Our job in intubation really is to help prepare the baby, the family, and be ready for the provider when they come. Our reasons for intubation vary depending on what's going on with your baby. I brought back this chart here that we've talked about a few times. This is a respiratory escalation chart. So you may have some babies that need to be intubated because they have their underdeveloped lungs and they're exhibiting signs of respiratory distress syndrome. That might be in their x-ray, where it looks like they have a little bit of high-volume membrane disease. We're going to look at x-rays on the next slide. It might be from their work of breathing. It might be from their oxygen requirement. Sick-term babies might need it, again, for meconium aspiration. I think about that one big time because we also used to intubate and suction out most babies born with meconium aspiration. We'd carry them over to the resuscitation table so they wouldn't really move or cry or anything and go in and suction, do deep suction with intubation. But we don't even do that now. So now we're kind of waiting to see what was the effect of the meconium aspiration. Same thing with high drops, with any of our situations, polyhydramnios, infant of a diabetic mother with maybe low surfactant production. Those are the babies where we might not do it right away, but we may end up intubating them. And then, of course, any baby that maybe was intubated or we're trying a non-invasive ventilation and they're not doing well. So that would show us with poor gas exchange, whether in a blood gas or TCOM, rising O2 levels, severe respiratory distress, so really retracting, grunting, flaring. And then this use of non-invasive support with escalation as high as you can go. So if we've gone from CPAP to NAVA or NIMV, remember the difference between those two is that CPAP does not have a rate and NIMV will have a rate, will have a high pressure limit. So we've kind of maxed out what we can do and the baby still isn't doing well, and or we decide that they need surfactant. These would be all reasons that we could see for an intubation. This list is inclusive but not exclusive. I'm sure there are some things that I have not completely talked about. So if we look at some x-rays here, you can see in this red line we've drawn here, we see a little bit of a pneumothorax. that could be an indication for intubation. Here, where these arrows are pointing, we see some of that hyaline membrane disease, where this is a lack of surfactant production. Here, we've got some air trapping, some whiteout. There's fluid just kind of stuck there that the weak baby isn't able to get out. None of these babies have breathing tubes, as you'll notice. There's no breathing tube here. So this would be a situation where it would be time for intubation. Your providers decided it's time for intubation, so we're going to gather our supplies. One thing I have found that helps teams be very successful is to have a respiratory cart or a toolbox or a bag, something where they have all these supplies already gathered. Because what is so important to remember when preparing for intubation is you don't want one of everything. You don't want one ET tube. You don't want one, neobar or face tape, whatever you're going to use. One CO2 detector. Anyone dropped it on the floor before? Anyone? Just me? Because in the situation where you have one of something, inevitably you're going to need another one. So it's best to start with many. So you're going to need your appropriate sized ET tube with a stylet if preferred. Again, in my diverse practice of intubating mannequins, I don't know how anyone doesn't use a stylet. But remember that our primary tubes that we use in the NICU are a 2.5, a 3.0, and a 3.5. So less than 28 weeks, you're probably getting a 2.5. 28 to 32, you're going to get your 3.0, and 32 and above, you're going to get a 3.5. Those are broad statements. So we have this idea where if you are less than 28 weeks or less than 1 kilogram, you're going to have a 2.5. If you are 28 to 32 weeks, that does not look like an 8. And 1 to 2 kilograms, you're probably going to need a 3.0. And if you're greater than 32 weeks, or 2 kilograms, you will need a 3.5. These are rough statements, right? A good clinical, quick way to know what to have. Again, what if a baby was intubated, has been extubated for 2 days, is having signs of respiratory distress, and they have swelling in their trachea? You may not be able to use the same size tube. You may not be able to use something from this recommended chart. So you're going to need your laryngoscope, your handle and your little blade. Learn how to put them on together. Make sure you have the right blade. We typically use a 00 or an O in the NICU. Your resuscitation bags, I have 3 here. I have a self-inflating, a flow-inflating, and a T-piece resuscitator. The T-piece is the preferred method. We have talked about this extensively because of the consistent pressure you are going to get on everyone. Always have a different size mask. You're going to be doing PPV with your bag mask in between attempts or before the attempt when they've taken off your NAVA or your CPAP, whatever was on. Make sure you have different tapes. And then, of course, your CO2 detector. So we've got all of our supplies gathered. We've got suction. Make sure your suction works, that it's ready to go. Have them open the tube size that they ask for, the blade size that they ask for, open and ready to go as your provider is gathering. You may also want to consider medications. Medicated intubation or rapid sequence intubation is the evidence-based practice that A, gives us the most success, and B, is the most comfortable with the baby. Remember, drastic changes in a baby's pain level, their CO2 levels or oxygen levels, and this attempts and what we're doing to them does increase their risk for comorbidities such as IVH. So what can we do to make them the most comfortable? In an emergency situation, if you are in a code, we don't do this. If you're in an in-between zone where maybe you are on 100% oxygen and your TCOMs are rising, or maybe you've had some apneic episodes, we may not give them these medications. But in most situations, if we can kind of catch them before they've gotten to those places, it is best to give them. So we would want to give them the medications in a safe manner, which is usually your pain medication first, whether you're using fentanyl or morphine, some atropine, which is going to help keep their heart rate up, and then your paralytics. Succinylcholine is what I have seen primarily, and fentanyl is what I've seen primarily. I worked at a facility where we called this fast, but you don't do it fast. So fentanyl, atropine, succinylcholine, and then have your tube ready. Because as soon as those paralytics get in, someone needs to be intubating the baby. So you never give a paralytic prior to having someone that can intubate in the room with the laryngoscope, with the handle and blade in their hand, ready to go. That is where you're going to get your success. This is rapid. The medication should probably be in within about 5-minute time span. What I always say is if you have the time for someone to be slowly taking off your CPAP or your Nivnava or your NIMV, set up your Fisher-Paykel, you have time to get medications. So get the medications, give your fentanyl slowly, prevent your chest wall rigidity, get your atropine going, and then get your paralytics such as succinylcholine. Afterwards, you may need some more sedation. You might just need another bolus of pain medication. You might need to put them on something continuous. And then, of course, our surfactant administration, depending on the reason for intubation, but especially on those premature infants or those late preterm infants who are just struggling a little bit. During the procedure, really what we as the bedside nurse are focused on is getting the baby positioned. I know as a rookie NICU nurse, I've had a provider come in and the baby is laying in a way that we can't even intubate them. So these are mannequin pictures. I feel like I need to say that so everyone knows. But we want to be standing with the baby positioned at the head of the bed, the head so that the provider can get to them. So depending on what kind of beds you have, if you're on a radiant warmer, the baby's going to go all the way around so that their feet are at the end where the heat source and your buttons and all of your sets are. If you're in an incubator and it has a little lazy Susan function, you may be able to just swivel the baby so that they are, one person can stand at their feet, one can stand at their head, or all the way kind of that 180 where their head is also at the bottom. If they're in an open crib, you might need to get them on a table depending on what they're there for. Get everything ready. Someone's going to start looking. How long should an intubation attempt take? What does NRP tell us? About 30 seconds. So once the provider starts looking and we have removed that PPV, so right, that PPV was giving them the breath through the NEOT or whatever, you're giving that PIP over PEEP, and we remove it, we should really try not to have that off of a baby for more than 30 seconds. So the provider is going to look. You may be asked to hand suction. You may be kind of helping to contain the baby, doing some extra hand holding and hands on the baby to really help them be successful. They will get the tube in. We will start bagging again with the CO2 detector in place and see what's going on. Get the CO2 in. It comes out purple, which is sad, and it turns yellow, which is happy, right? So you want to see changing to yellow and then listening. So you should, at a bare minimum, have your neonatologist, your NNP ready to go. You need to have your respiratory therapist there. You need to have yourself and then somebody else to kind of document and get your meds ready. Bare minimum is 4 people. I say 5 to 6 is probably good in case you forget something, supplies fall, etc. So the other people could be sitting outside the room if it is too crowded. You as the bedside nurse, you know your baby. You know what their breathing looked like before. You know what their oxygen requirement was before. Maybe you've seen them intubated before. You need to be with your baby. Allow that extra nurse to be somebody that's drawing up the medications or doing some documentation for you. You also know what your access is. So if you are there, you can say, yes, this IV looked like this. It's good to go. Let's give these medications, or this is the PICC line, etc. So be ready at the baby's bedside. Have your suction ready. Your RT might be in charge of the suction. Very plausible. They will be in charge of handing the ET tube to the provider when they ask for it. So we are a team here. This is where those team dynamics come in. Having a pre-brief to pause. You're going to do your timeout. Is this the right baby, the right procedure? Do we have the right supplies? Do we have both a 2.5 and a 3.0 tube? Do we have the 0 and the 00 blade? Is our suction connected and working? There's your little pre-brief. RT, I'm going to be in charge of this. Bedside nurse, I'm going to be in charge of this. Extra nurse, NNP, I'm going to do these jobs. Great. 30 seconds to pause, pre-brief, and proceed forward with your procedure. Our jobs: ensure proper positioning. Stay prepared to assist with suction and ventilation. Monitor the baby's oxygen and vital signs closely during the procedure. Also let them know when it has been 30 seconds so that the attempt can stop and we can resume PPV. So here's our confirmation of placement. These x-rays are not fully resolved x-rays yet, so let's not dive into that, but let's look at our ET tubes. Our ET tube should be between our clavicles and our carinas, our 2 C's. So we have this, these orange circles we've got here that show us where our ET tube is. I could maybe be talked into this one being borderline too low, but that would be nitpicky for me. So post-extubation x-ray is the gold standard to make sure your tube is in the right place. If you have color change on your CO2 detector, you're most likely in the right spot. The other forms, such as bilateral and equal breath sounds, mist in the tube, no air over the abdomen, are not definitive. We may use those as we're waiting for the x-ray and say, yes, I'm seeing these, let's move forward with the x-ray, let's kind of do the next steps, but we're not always sure that those are the right and best ones. CO2 detectors can also be late in detecting the change if your baby's cardiac output is poor. So if your heart rate was down for a long period of time, you may need to give the purple time to change to the yellow so that we can actually circulate the oxygen and the CO2 to exchange and then get out through the exhalation. So make sure you're kind of having that little bit of patience there. But if you do a quick glance at the x-ray, this is what you should be seeing between the clavicles and the carina. So for our parents, this is really scary. Even in a delivery room, watching an intubation as a parent, it has got to be horrifying. I have not had that experience as a parent. I've obviously had it as a nurse. Watching them go through it, it's terrifying. In the NICU, it's still terrifying. But in the NICU, we probably have time to pause, explain what's going on, explain what we are looking for that signs that the baby is getting better. Remind them that this is most likely a temporary solution, that we will transition them off, whether we end up needing to use meds like we talked about last week, or if we can just change their pressure over time to get them off of the ventilator. So our signs of improvement, you should be seeing decreased oxygen requirement, decreased apnea and bradycardia, decreased work of breathing so that they will look more comfortable while they're breathing, and overall stability. Some things that might say, hey, what's not going well, even while intubated, is really important to teach your parents because they are the primary caregiver of their baby. Cannot stress that enough. They are the ones that are there every day, in and out, watching what's going on with the baby. So they will notice if there's increased work of breathing. If they are holding their baby and they're like, wow, this is not what they usually feel like, or there's way more alarms happening, or I actually am hearing my baby cry, you may have an unplanned extubation on your hands. So giving them the power, empowering them with the knowledge of, hey, this is what we're going to do. This is kind of how we expect it to go. And then this is how you can watch your baby and tell us what is going on. And if you notice any changes, is going to be transformational in your care of this baby. The other thing, there are, I would say, pluses and minuses to having parents stay for intubation. For the most part, I am for it. I think offering them and what they choose to do is up to them. I do think it gives them the knowledge of kind of what we're doing, and it doesn't feel secretive or that something bad's going to happen. Inviting your parents, hey, would you like to stay for the procedure? It can look intense. It can seem like we're trying for a long time. We are going to safely get your baby intubated. We are going to be monitoring your oxygen during it. We're going to monitor your heart rate. We will stop the procedure at any time and allow your baby to recover with PPV if we need to. So being transparent and kind of what they're going to see, I think, will also be super helpful in these conversations. So we know that intubation is a crucial procedure to help babies breathe when they're unable to do it on their own. Educating our parents, reminding them this timeline is going to vary, that we can't give them this answer of, hey, this is exactly how long your baby's going to be intubated, but these are some signs you can look for that your baby's doing better or that they're not doing as well. Ensuring safe intubation, remembering that teamwork. There's so much power in a pre-brief and a debrief. Hey, we got that procedure done on the first attempt in 20 seconds. Let's talk about what went well. Oh, we had our pre-brief. We had all of our supplies we needed. What didn't we have, or what could we have done better? You know, we probably should have considered bagging on higher pressures because of their x-ray. Whatever it is. So much power in the NICU nurse and their presence at the bedside during the procedure, assisting and also leading those pre-briefs and the debriefs so that the NICU team can be successful. Thank you for joining me this week for this Teach Me Tuesday. I hope you learned something. Please like, comment, subscribe, hang around with me, find me on Instagram, find me on TikTok. But I hope you have a great day, and I will see you next week for another Teach Me Tuesday.